All right, good afternoon, everybody. Thank you for joining us. This is the breakout session during the City Match Conference called This is the Way We Rise. And just to get us started, I wanted to introduce our speakers for today. They can tell you more about the work and the things that they do. But briefly, I'm so excited to have Alyshia Macaysa-Feracota, Borja, and Margaret Braun with us today. They are from the state of Oregon and have been doing very important things to really ensure that the data that we collect really serves the Pacific Islander community in Oregon. And so we do have a great session planned for you today, and we will have time for questions at the end. So if anything comes up, please feel free to make use of the chat. If you have questions, thoughts, comments, and then we'll address them when we can. And so with that, Alyshia, I'll turn it to you to get us started.
Awesome, thanks, Lynn. Well, aloha mai kako. Hello, everyone. Good morning, good afternoon. My name, like Lynn said, is Alyshia Macaysa. I am one of the 3 members of our team presenting today on what we call This is the Way We Rise, Decolonizing Data Modernization for Pacific Islanders in Oregon. And I'm really excited to talk about this body of work. It's also years and years of work. So I hope, the 90 minutes that we have planned can do it justice, while still leaving enough time for you all as our audience to ask us questions, share your thoughts. We want to hear from you as participants about how this work is landing with you and what questions you may have. But before we get started, I want to first acknowledge the indigenous folks in the indigenous land on which we, as an Oregon-based team, do our work. And I think it's absolutely critical, right? I mean, we have the word decolonizing in our title, and we also, as Pacific Islanders, are really connected to the indigenous struggle as indigenous people of Oceania. So I want to start by grounding us in this acknowledgement that the United States was built on broken treaties. The lasting effects of federal and state policies, both past and present, have systemically oppressed Alaskan Natives and American Indians for hundreds of years. And it is on all of us, whether we are descendants of colonizers or inhabitants of stolen land, or a mixture of both, to decolonize and act in solidarity with all Indigenous peoples around the world. But we would like to especially honor and acknowledge the Indigenous peoples and rightful owners of the occupied land in which we do our work. And that includes the Klamath tribe of the Southern Oregon Plateau, the Burns Paiute of the High Desert East, the Coquille of Southern Oregon's coastal forests, the Confederated Tribes of Grand Ronde in the Northern Coast Range, the Cow Creek Band of Umpqua in the Southern Oregon foothills, the Confederated Tribes of the Umatilla in the Blue Mountains, the Confederated Tribes of Siletz in Oregon's northern rainforests, the Confederated Tribes of Coos, Lower Umpqua, and Siuslaw on the wind-blown southern coast, the Confederated Tribes of Warm Springs on the sunny eastern slopes of the Oregon Cascades, and all Indigenous communities who hold ancestral ties to the land that we work on. And, we'll talk a little bit more, of course, throughout the presentation about, building with our Native American family and community here, what decolonizing data and research means to us, what action and solidarity look like, that's all threaded throughout the story that we're hoping to share with you all today. But we wanted to start with that grounding. We can go to the next slide. Great. So what we're going to be covering today is, our hope is that we can share with you all this big body of work, like I was talking about, that's been going on for years in Oregon. And the goals really are that you all really understand the impact and trust of relationship building on the data and research process. We also want to provide this as an opportunity for folks to really question dominant culture values when it comes to certain types of data and even credentials in the research process. We also want to share about and give you all the opportunity to learn about the strengths and challenges of implementing a culturally specific community-led research model. The 3 of us on the call will talk extensively about all the really incredible things that we got to do with our Pacific Islander community, but that doesn't come with, without challenges. we also want to make it really clear, because I know we have a lot of government folks on this call. We want folks to understand what's possible within government systems, and that it is possible for our government folks to show up as responsive partners in community-led research. And then, last, we really want to emphasize that the amount of resources and capacity that it takes to do community-led research, authentic community-led research. And so with those goals in mind, what we're hoping to cover is tell you a little bit about what is Pacific Islander data modernization, right? What are we talking about? Then we want to go through, well, why is this work significant for us as a community and for the state and the work that they're doing? We'll tell y'all, we'll explain a little bit about our community-led research model. What does that mean? What did it look like in this work? And then we'll give you a preview of what we call the Pacific Islander Health, Equity, and Liberation Assessment. So that's the research tool that we developed with our community. We'll talk about the data collection process. We won't go through the results in detail, but we do want to share some of the things that really struck us, some of the things that we heard loud and clear from our community about their stories, their experiences, right? The results. And then we'll share a little bit about like the path forward, kind of what are we doing next? What are the things we're thinking about? Well, our team will end with some reflections. And then again, I'm hoping to have about, at least 15 minutes of time to interact with all of you, to do some questions and answers. And of course, that can also just include reflections and thoughts from you all. So that's what today looks like. We can go to the next slide. All right, so what is Pacific Islander data modernization? So every year, the Oregon Public Health Division collects health data on adults using a telephone survey called the Behavioral Risk Factor Surveillance System, or BRFSS, which I'm sure many of you are even experts at, or you're your state lead on implementing the BRFSS. And the BRFSS in Oregon is used to drive policy and programming decisions. And the challenge here for Pacifica people is that even in years with an intentional racial and ethnic oversample, BRFSS data collection has historically resulted in an insufficient number of Pacific Islander participants and a lot of culturally irrelevant data that community organizations aren't able to utilize, community members may not understand or see the value in. So there's a ton of challenges around it, right? And so this is the way we rise. And this presentation today is really about sharing the story of Pacific Islander data justice advocates and our partnership with Oregon Public Health Division to bring a community-led research model into the state's data modernization initiative, because we are one of many communities that are part of this work. And so this session is really going to detail how we used our data sovereignty agreement with Oregon Public Health Division to develop both a research process and a community health assessment model that was really rooted in, indigenous wisdom, values, and culture. We can go to the next slide. Hey, City Match folks, do we want to advance to the next slide? Awesome, thank you. So as you see, there were a ton of folks involved. I won't read everyone's name off here. I think that would probably take us the next 30 minutes, but I just wanted to show this visual, right, of like so much of our community was involved in this process, led this process. They were the organizations that were involved. They served as community research workers. We had Pacific Islander language experts. We had project consultants that have had long relationships with the community. And then, of course, we had our core research team, which myself and Dr. Braun are included on. And then, of course, we had our folks from the state, specifically from the Program Design and Evaluation Services, the Survey Modernization team. So I just want to show this to show like really the breadth of capacity and resources and people that were involved in making this work possible. But I want to pause here, and actually we can go to the next slide and just introduce who's on the call today. So like I was sharing earlier, my name is Alyshia Macaysa-Feracota. My pronouns are she, her, hers. I'm the executive director of the Oregon Pacific Islander Coalition, and I served as one of the core members of the core research team. And I'll turn it over to you, Bella, if you want to intro real quick.
Thank you, Alyshia. I just want to make sure, can everyone hear me?
Yeah, you're good.
Awesome. Hi, everyone. My name is Bella Borja, and I use she, her pronouns. I am a project director with the Micronesian Islander community. And in this project, I was a community research worker. And I wanted to just share a little on the importance of being involved in Pacific Islander led research. One of the things that we find is that a lot of PI research has low engagement, and when we have PI-led research, we find that engagement is much higher. So thank you.
Mahalo, Bella, and Margaret, I'll turn it over to you to intro.
Thanks, Alyshia. Hi, everyone. My name is Margaret Braun. I use she, her pronouns. I'm a research scientist with Program Design and Evaluation Services. Here today's representing the Oregon Public Health Division, which is the public health division within Oregon's state health authority. I am one of my role in Pacific Islander data modernization was to play kind of a technical assistance role and be the bridge between the core research team and the state. And just a little bit about what I feel is important to be involved in Pacific Islander-led research is before having the honor really of joining this team and working on Pacific Islander-led research, I admittedly knew virtually nothing about Pacific Islander cultures, communities, and the people. And since I've been able to do this work, I can say that number one, I had no idea what I was missing. And then also being able to play a part in being that bridge in the gap between Oregon Pacific Islander communities and state and local government who have chronically neglected Pacific Islander communities. It feels very critical to me professionally and personally, both from a data perspective and from a social justice perspective.
Thanks, Margaret. Now we've looped you into all our projects, so now we won't leave Dr. Braun alone. All right, so let's go to the next slide. Let's jump into it now that you know who's here on the call with you today. So we're going to talk a little bit about the significance of this work. We can go to the next slide. Awesome, thank you. So I think it's important before we dive in for folks to really understand Pacific Islanders are indigenous to Oceania, right? Our home is the Pacific Ocean, the largest water mass on this planet. And by colonization standards, right, Oceania is technically made up of 3 ethnographic regions. So that includes Melanesia, Micronesia, and Polynesia. I think in really dominant culture or like stereotypical conversations of Pacific Islanders, a ton of our cultures and history and language really gets blended, or it tends to be this really Polynesian dominant narrative. And so that's why it's really important for me to break down for you all the breadth of communities and histories and language that we're attempting to talk about, right? Oceania is made up of over 20,000 islands, over 30 recognized nations, and a large breadth of villages, clans, chiefly systems, languages, histories, ethnicities, that people don't really understand. And so like its waters, Pacific Islanders hold rich and vast experiences, right? Rooted in our culture, language, and a deep kinship with our ancestral lands. And so this rich vastness, along with our unique history and our specific connections to health and well-being, it's often erased in data and research. And so, like I said earlier, we're going to share some of the results from this work with you all, but we wanted to take a moment to name this to really emphasize that overgeneralizing Pacific Islanders, right, and not taking the time to do the work to even disaggregate the term Pacific Islander and failing to understand what is unique to each community is really a disservice to health equity and a disservice to the work that we're trying to do. And so let's go to the next slide. So I'm going to turn it over to Bella for a moment to just talk about some of those, unique cultural values and experiences.
Thank you, Alyshia. So yeah, as Alyshia described, Pacific Islanders come from all different areas of the Pacific. Most PI cultures, if not all, are collectivist cultures that emphasize the needs and goals of the community in order to survive and to thrive. However, we have to keep in mind that there are dozens of different cultures, and while they may share a similarity in those cultural values, the daily practices, customs, and traditions can look very different. And the same is true for health practices. And so one example that I want to share is in postpartum care. So for the Palauan culture, an important tradition is that omangat, that honors a woman's victory after birthing her firstborn child. The process occurs over the course of 5 to 10 days. She begins with her hot bath ritual, which happens 1 to 3 months after giving birth. This bath is done by family members. She drinks herbal teas, to which each tribe has their own specific blend. Her body is then coated with coconut oil and ginger, and then she is dressed in traditional Palauan clothing and then presented to her husband's family, after which the husband's family will then place Palauan money around her neck. And this practice is meant not only to heal the woman's body, but also to symbolize her transition into motherhood and to help establish a bond between the two families. Similarly, another community in Micronesia, the Marshallese community, they also have cultural postpartum care practices. And so their care practices involve the new mother receiving a massage, which massages not only her body, but also her uterus. She's then instructed to sit by a fire to warm her body and then given an herbal bath. After the woman is wrapped in a girdle made out of pandanus leaves, this is meant as a form of healing for the body from childbirth, and also to help realign the uterus. During this process, the new mother is not allowed to do several things which may interfere with the healing process. And the long-term effectiveness of this postpartum care process is typically measured after a year. So as we can see, these are two very different cultures who hold similar values in that the community is involved in postpartum care, but the actual practice is vastly different. And while both cultures focus on the healing of the mother, the Palauan culture involves a social component of building ties with the father's family. Whereas in the Marshallese practice, it is more medicinal and involves specific blends of herbs that are unique to each clan. And so really, what does this mean to be Pacific Islander here in Oregon? One really important thing is that we need to acknowledge that each of our cultures may have similar values, but how we practice that and what is important for our health and overall wellness is very different. And most importantly, they may require different resources. So this may mean that different cultures require access to specific herbs, oils, and other plants. Some may require actual physical space to hold ceremonies. Health is not simply going to the doctor and receiving medicine as a form of care, but it's also holistic and involves the community.
Mahalo, Bella. And, I think with the examples that you're sharing, right, like some of that cultural protocol, like we had to navigate in the way we designed our data workshops, right, of like, how do we talk about health? What relevant questions do we ask? How do we even structure breakout rooms to respect what cultural protocol is for our different communities? Because they all don't feel comfortable talking and sharing about health in the same way. And right, like different questions are what's going to elicit their responses on like health and healing and community. So mahalo for sharing. Yeah, so let's go to the next slide here because I'm going to turn it over to Margaret, right? So Bella and I just talked a little bit about what's the significance of this work from our perspective as folks that are part of the community. But I also want to make space because I know this is a really significant body of work for our state partners. And so Margaret, I'll turn it over to you to talk about that.
Awesome, thank you, Alyshia. Let me first describe a little bit about my unit's role within the broader Oregon Public Health Division. So my unit, which is Program Design and Evaluation Services, or PDES, is an applied research and evaluation unit that's shared between the state's Public Health Division and Multnomah County Health Department, which is where Portland is located in Oregon. Our unit employs about 25 folks who are public health researchers, epidemiologists, program managers, and specialists. And we do a wide range of work with a lot of different partners. But relevant to this project is that our unit oversees the Public Health Division's survey unit, which leads the implementation of the Oregon Student Health Survey, which is Oregon's version of the Youth Risk Behavior Surveillance System, or YRBSS, which is what you might be more familiar with. And then we also oversee Oregon's Behavioral Risk Factor Surveillance System, or BRFSS. You can go to the next slide. So Oregon, like many other states, relies very heavily on the BRFSS for data on statewide and community population estimates of health, healthcare, chronic conditions, and demographic information. And so since my unit oversees the implementation of the BRFSS, we're kind of in a unique position that allows us to see very clearly its limitations and its challenges. The BRFSS faces a lot of challenges to its data quality, its validity, reliability, and sustainability. And specifically, those are the BRFSS is very expensive, particularly when Oregon invests millions of dollars in enhanced efforts to collect sufficient responses from communities of color, which is what we call a race and ethnic oversample. As a random digit dial survey, interviewers have to call many phone numbers to meet their survey response goals. The BRFSS also covers very sensitive topic areas like adverse childhood experiences, food insecurity, housing insecurity, and so on. The BRFSS also lacks community engagement. Communities have not been engaged in creating or prioritizing content for BRFSS, data analysis, interpretation of results, or dissemination of the results, but their involvement and input in all of those activities is critical for the state's understanding of the data and assuring the utility and accuracy of the findings. The BRFSS is also very long because it's the main health data resource for local and state public health programs in Oregon. More and more questions over the years have been added over time. And the length causes interviewers to potentially rush through those questions, which, as I just mentioned, can be sensitive and potentially even traumatizing. So for these reasons, among others, the BRFSS is particularly problematic with regard to Pacific Islander community member participation. In Oregon, Pacific Islander participation in the BRFSS is so minimal that we don't have enough numbers to calculate reliable indicator estimates, which is the whole point of the BRFSS from an epidemiological perspective. And quite frankly, why should Pacific Islanders participate, right? Pacific Islanders have never benefited from their participation. Why would they subject themselves to a survey that's not aligned with their community's priorities, not informed by their community's perspectives on health and wellness, not offered in any Pacific Islander languages, and it's administered by interviewers who likely do not have the relationships, the cultural competency, or the trauma-informed practice that's necessary to engage Pacific Islanders. So as I mentioned, my unit is uniquely aware of the challenges with the BRFSS, and therefore we were also well positioned to advocate and be a champion for exploring other methods of collecting data that would be more representative and valid. And, I think you can go to the next slide, sorry. So that awareness combined with this long-standing relationship within the Oregon Health Authority's Office of Equity and Inclusion really set the stage for various projects that helped inform survey modernization efforts in general, and then the Pacific Islander Data Modernization Project specifically. We started with grant funds and our contract with the Office of Equity and Inclusion, which allowed us to partner with the Chuukese community in Oregon on a project called Community Counts. This was a pilot project testing a respondent-driven sampling approach to conducting the BRFSS with just one Pacific Islander community in Oregon. And our experience combined with, our experience with community counts combined with leadership support made it possible for us to request general fund dollars to support the work. which is really the only way that we've been able to sustain this effort. You know, as we all know, grant money runs out, grants end, and as the money runs out, you can't do the work anymore, but general funds really allowed us to keep going.
Thanks, Margaret. So, you know, let's dive into it. The community-led research model, right? We're hearing about the significance, kind of the work the community's been doing on our end, you know, what led the state to really invest in this work. And so for us as Pacific Islanders, like many other communities of color, we have a tumultuous relationship with data and research. It tends to be an incredibly extractive process where, like Margaret said, we don't really see the benefit or cultural relevance of it. And we're often really disconnected from like a lot of the strategic conversations around it. So for us, it was important that we built a project infrastructure that really valued Pacific Islander leadership and wisdom. And, you know, when Dr. Braun and her team approached us to collaborate, we said, yes, you know, let's definitely talk about that. But we want to set the tone outright from the start of the project of this is how we're going to do it. You know, if we're going to engage in research, then it's going to be about capacity building. It's going to be about relationships. It's going to be about decolonization and justice. And so let's go to the next slide. So a core component of what we did is actually we created a data sovereignty agreement with our state partners. And within that data sovereignty agreement included the vetting process that I just mentioned. But what we also came to an agreement on with the state was that, you know, the community's role is we're going to serve as the research experts, the engagement experts, the language experts, and the writers, and, you know, data, and, you know, serving as the analysis function of this work. And for compensation, right, we want them to know that we're going to set up this budget in a way to where the community is properly compensated for the expertise that they provide at every single stage of this project. And we also wanted to make it incredibly clear with our state partners that the government's role here is that Oregon Health Authority's Public Health Division is a technical assistance resource, right? So they're supporting us with the research, they're supporting us with the funding, other resources that they may have, but they're a technical assistance resource rather than the governing body for this work. And ownership, right? If you want to talk about sovereignty and decolonization, then at the end of the day, we do have to have this conversation about ownership. And we've made it clear to the state that the community owns this data. We own this report, right? And we have first presentation and publication rights. Our community must always be a part of presentations. In fact, we want to be leading what the dissemination and presentation plan even looks like, and that we have to be a part of strategic planning conversations with government. And let's go to the next slide. So with that sovereignty agreement in mind, you know, there were different, you know, stages and methods and opportunities for community leadership. So I'm going to turn it over to Bella to talk about her experience and perspective as one of 10 community research workers on this project.
Thanks, Alyshia. Yeah, so I want to talk about kind of what the process looked like, and then I'll share a little bit about my perspectives. So the first part of the process was that CBOs were engaged from the very beginning. So CBOs were able to help co-design and then approve workshops. They led community engagement, and then they also review data. The PIDM staff met with CBOs and CRWs such as myself to co-design the workshops together. And during these workshops, both the CBOs and the CRWs had the opportunity to see the HEAL assessment, ask questions, and then to plan the community work sessions, which, you know, took into consideration the things that Alyshia talked about earlier in terms of like, how do we do breakout sessions? How, you know, are we going to do this in the most respectful way? How are we going to ask questions to elicit responses? This also allowed for in-depth conversations and feedback from CBOs and CRWs to the PIDM team about the HEAL assessment itself. CBOs led the engagement by doing the outreach for participants and inviting their communities to attend the meeting. And then there were also alternatives for the HEAL assessment if people were not able to attend. Such as providing the survey links The next part was CRW, or community research worker led facilitation. So again, CRWs were a part of this process the whole way through, helping co-designing the workshops, led the data workshop facilitation, reviewed data, and then co-designed the analysis framework. So along with the information sharing about the assessment and doing the assessment itself, community members have the opportunity to engage in small group and large group discussions. And these discussions focus on feelings and reactions to the assessment items, which gave community members the opportunity to share their feelings, concerns, and experiences with the different assessment items. And for some, it was their first time considering the items and the amount of resources available to them, their family, or community. And for others, they were acutely aware of the unavailability of specific resources and its impacts. Everyone contributed to reviewing and approving the drafts and final report, provided recommendations, reviewed and approved graphic design, which turned out so lovely. And so after the end of each community sessions, the CRWs were given the opportunity to go over the data with the PIDM staff and engage in feedback, provide clarification, and then really emphasize what were the really important things that community members had to share. And so this was important and very different from how Pacific Islander communities have typically been engaged. This really called for and encouraged, discussion outside of what was written on the assessment. And typically, the PI community, when they're asked to participate in any type of research or any form of providing feedback, they're really just asked to come and answer questions. And this is often requested without thoughtful ways to manage language or communication barriers, or even establishing trust between the person asking the questions and the community. So then what typically happens is that a meeting will be held. The community may not want to disclose and specific things or really anything to the group. There's silence, and then the meeting ends early. And what I found in doing this work is that many PIs are expected to engage like Americans, or to engage in an Americanized way, where they compete to see who has the loudest voice, and that's the voice that's going to be heard. And oftentimes PIs will sit and listen, as humility is a large cultural value that is ingrained in many PI cultures, and not all. And it doesn't mean that Pacific Islanders don't have anything to say. It really could be quite the opposite. However, when we approach research expecting the community to be engaged in specific ways, such as speaking first and speaking the loudest, is the only way to get your voice heard, that strategy often fails to capture the breadth of contributions that could be available if teased out a little bit. So as a community research worker, the process for me was really engaging. It was unlike any other project that I'd ever been a part of. Leaders really made it a point to be mindful of the different considerations that might impact not only the community's ability to engage, but also impact CRWs, or community research workers' ability to participate. So some of the unique things that I experienced were that PIDM leaders ensured that the community research workers were compensated for the work. Leaders did not wait until the end of the project to compensate the CRWs for the work that they were doing. We received partial compensation at the beginning. And then PIDM leaders also ensured that there were different forms of payment, keeping in mind that not all people have access to a traditional bank account. So there were alternative options for payment, such as PayPal. And then since the meetings and workshops were virtual, PIDM leaders also wanted to ensure that technology access would not be a barrier or hinder participation from CRWs. And so a technology access stipend was provided to all CRWs that could be used in whatever way to ensure that they were able to participate. And altogether, those logistical pieces and considerations for engagement with the community research workers, the community-based organizations, and the community itself made the process very successful, in my opinion.
Mahalo, Bella. You know, it's funny, folks, because when we were preparing as a team, you know, Dr. Braun and I said to Bella, you know, be honest about what your experience was, right? Like things went well, but also that there weren't things, you know, there were things that we wanted to improve on, or there were still gaps, right? We tried to use our funding really intentionally, but at the same time, we couldn't possibly address all of the inequities that show up in a research process. But I'm still relieved to hear your report back, Bella, of like, you know, it felt good. And that's really important to us, because like I can't emphasize enough like how extractive research can feel in our community, like Bella was laying out earlier. So let's go to the next slide. So one of the exciting parts about having Pacific Islander leadership and the relationship that we set up with the state was, you know, Dr. Braun came to us and asked, well, you know, do you all want to use the BRFSS? And do you want to transform some of the questions? Or is there something else that you all really want to create? And she really encouraged us, right? To like, there's room. If you feel compelled to create a different kind of tool, then let's do that. And so and when I say we, I mean our community members, right? Again, we did a ton of extensive engagement sessions on like, what is the tool that best captures Pacific Islander experiences? And so what we came up with was the Pacific Islander Health, Equity, and Liberation Assessment. And so what Bella was referring to earlier as the PI HEAL assessment. So let's go to the next slide. So I'll tell you folks a little bit about what's in the assessment. I'm not going to show you the full assessment. It's actually not too long, but I couldn't fit it on the slide. So this is what you're getting. So the PI HEAL assessment has 16 different community health factors. I'll also name that this was modeled off of Prevention Institute's Thrive tool that focuses on the social determinants of health. So what we did is we sat down with the community and we said, you know, do these look like relevant determinants of health that we want to talk about? Or are there other things specific to Pacific Islander cultures in our community's health that we really want to talk about in this project? Because this is an opportunity, right, for us to be visible on a stage and in a space that historically, you know, we've been excluded from. And so what we came up with were these 16 different community health factors that you see on the left side, right? So there's those 4 main categories. You've got people, place, opportunity, and also healing. So you may be familiar with some of that if you've done social determinants of health work, but also I'm sure some of this language is really new because we as Pacific Islanders made sure to take up as much space as possible in designing this assessment, right? And so, you know, we have different factors within those 4 categories. We've got community connections, care for community, the larger values of the community. Are those present in our lives? You know, housing, food, access to land, getting around, cultural centers, living wages, local wealth, education, and information. And then also self-determination, decolonization, spiritual health, and healthcare. And one of my favorite parts about this tool, well, there's a bunch, right? The first is, you know, in a lot of health assessment tools, we often see this rating scale of like rated A through F, right? Is it good? Is it bad? Is it somewhere in between? Is it performing well? And when we looked at all those rating scale examples, we're like that just doesn't culturally connect. And, you know, it's not about this hierarchical value for us. What we want to talk about is abundance. And like, are these resources that we're talking about, are these health factors available to our people, not just to ourselves as individuals? And so we have this really awesome rating scale with fish. We got feedback. One of our groups was like, we don't like the fish. It looks like Dr. Seuss. We want coconuts. We said, okay, you know, for your specific community, we can change the rating scale. But what we're primarily using here is the fish, right? So for example, if someone was reading the definition of community connections, they would say, like, you know, I don't think anyone, including myself or my family or anyone in my larger community, really has access to this. So they would circle something like the bonefish. But then we said, you know, in some cases, folks may say like, well, this is something I have access to, you know, because of my individual circumstances, but, you know, maybe someone from my family or in my community, like this is not available to the broader community, right? And it kind of builds up from there of like, yes, everyone has access to this. We feel like our broader community, our family members, and ourselves as individuals have access to this resource. So that's a little bit about the rating scale. The other thing I just want to briefly mention is, you know, I think the real beauty of this is we really wanted to shift from, you know, we're typically compared to the white dominant population in the state, right? When we're looking at health inequities, we say, well, this is where this community is, and this is where we are as Pacific Islanders. And then all of the policy and program planning is focused on like, how do we close the gap between those two communities? But the truth is that what works for one community doesn't always work for another community. And so what we really wanted to focus on was like, where are we currently as Pacific Islanders, and where do we want to be as people, as a community? And so because of that, one of the things that we did was like, well, let's create more of a desires-based rather than a deficits-based framework. Rather than talking about, so in these definitions, right, of the community health factors, we really took this abundance approach. We didn't want to just define these health factors as the bare minimum needs. We wanted to say, if housing strategies were developed with Pacific Islander cultures in mind, what would that look like? And so the two on the screen are examples of what we came up with. So we co-created these definitions or even like health metrics with the community. So for example, for housing, right, we weren't just talking about access to like affordable low-income housing, like Section 8 housing, which is obviously still a big need in our community. But we wanted to say, what would the ideal situation look like? So the definition that was developed is we want housing that is safe, it's affordable, it's quality housing, and that it can accommodate families of all forms and all sizes, whether that's chosen family, multiple families in one household, multiple generations in a household. And you know, that led to us being able to also talk about home ownership, land ownership, right? And we didn't want to limit the parameters just to like access to Section 8 housing. Again, important, but limiting. And so I'm going to turn it over to Bella to talk a little bit again about, from her perspective, like what's the significance and like the cultural relevance about, you know, assessing health in this way.
Thanks, Alyshia. Yeah, so I wanted to talk a little bit about the cultural significance of the framework that was used during this project. And so the rating scale provided and asked community members to rate the, you know, individual access, family access, and community access, like Alyshia shared. And this identified not only the availability of this specific items and resources to the individual, but also highlighted the amount of advocacy that is done by the community on behalf of the community. So individuals in attendance were able to identify if they had access, but also whether or not the other community members have access. And what we were finding was that people, you know, a lot of people were saying like, yes, I have access, but I know this person or that person, or, you know, my family doesn't have access, or, you know, my family and I have access, but not our larger community. And it's really important to talk about health in a more comprehensive way, in addition to, you know, determining access, because traditionally American health focuses on physical, mental, emotional, and then psychological health. But there are other categories that impact health that were included in this framework, such as healing and decolonization and nature. And these are important factors and values that impact the overall health of Pacific Islanders. So if we want better health outcomes, we have to take into account the elements of health that are essential and connected and who has access to it. So what did we hear? We heard people talking about the interconnectedness of issues for themselves and for their family members and communities. And these are the things that community members had already been talking about and forming their own connections. And so one example was that when talking about why people didn't have insurance, they related it to the fact that they didn't have a job. And they didn't have a job because they couldn't navigate transportation, and they couldn't navigate transportation because they didn't have a car. Maybe public transportation was too far away. And so those connections can really help highlight and address those critical factors that are impacting the overall health of individuals within individuals and the community, the PI community.
Thank you, Bella. Let's go over to the next slide. So, some of you are familiar with the BRFSS. You're like, well, this is totally different from that tool, right? The PI HEAL assessment. But if you're not, we just wanted to take a moment to reflect on how is this really different from the way the state is talking about or assessing health for different communities. So Margaret, I'll turn it over to you to speak about that.
Thanks, Alyshia. So like Alyshia said, we just wanted to give you a quick, just couple of examples about how the BRFSS might try to cover some of the same information that we covered in the HEAL assessment. So the first step is the community values factor of the HEAL assessment, which asks people to rate the accessibility and abundance of respect for the land and its indigenous people, a love for family, a shared responsibility to take care of the community. Elders are also respected. Youth have the opportunity to grow as leaders, and LGBTQIA+ people are included. So if you go through the Oregon BRFSS for 2022, the only thing that I could find that barely touched on just a piece of this factor are the questions around caregiving, which asks whether the respondent had provided care for a family member or a friend who has a health problem or a disability. So the important thing here to note is that not only does the BRFSS not ask about these different community values, but there's also the assumption in the BRFSS question that care would only be provided for a family member or a friend because they have a health problem or a disability, not just because it's part of what community does for each other. Then the second example that I have here is the healthcare factor on the PI HEAL assessment, which covers medical, dental, and vision insurance that covers holistic care for physical and mental health, delivered by people who are familiar with and respectful of Pacific Islander culture. Services are easy to get to, easy and quick to schedule, accepting of different insurance plans, and are affordable. And then the BRFSS on the right side, you can see there, asks just three major questions that align with this factor. Do you have health insurance? Do you have a primary healthcare provider? And have you had any recent barriers to accessing healthcare because of cost? So again, the BRFSS doesn't touch on holistic care, whether that care is delivered by someone the respondent trusts or someone from the community, and whether there are other barriers that might prevent them from getting care beyond cost.
Thanks, Margaret. So let's go to the next slide. So, we've told you a little bit about our actual tool. Now we want to talk about how we actually implemented the tool, right? How we used it, how we collected the data. And let's go to the next slide again. So, there were two main ways that community members could participate and share their stories in this work. So the first was by filling out the assessment online. So we made the overly ambitious goal to translate it into about 11 different languages. And because of everything happening with the pandemic, right, our language experts are totally tapped out right now. Like they are translating materials just kind of left and right. And so we were only able to implement it in 4 languages, but it was still important that we put up the assessments that were available. So community members could go online to our website and they could fill out the assessment online in either English, Olelo Hawaii, Pohnpeian, or Tongan. And like I said, we had it translated in other languages as well that's not posted. So that was one way. If they just wanted to quickly click through and mark, what the levels of abundance were for these different factors, there were places for them to provide additional commentary. But also in the beginning, we had initiated and in different languages, like, would you prefer for someone, a trusted community member to call you on the phone and support you with filling out the assessment? Do you want us to send you a printed out version? Like whatever resources they needed to participate, to have their stories heard, we wanted to make sure that was a thing. Because, the digital divide is surely an equity issue when it comes to the research we're trying to do. The other way was that they could attend one of 5 data workshops. So in those data workshops led by the CBOs and the CRWs that Bella was describing, folks had carved out time to fill out the online assessment. And then like she was sharing earlier, then we would go into this like deep facilitated conversation on why did you fill out the assessment the way you did? What do you want people to know about your story or experience as a Pacific Islander in Oregon? Like what's really important for you? And then of course, there was also space for them to give us feedback on the overall process and on the assessment itself. Because we know that this is just the beginning, right? Like this is a pilot process and we fully intend to continue this work, to continue to transform it to better serve our community. The last thing I'll emphasize is that, again, compensation, right? So workshop attendees were compensated $75. And what we told folks was, you are an expert in your experience and you are sharing wisdom with us, right? That's often not captured in research. We're compensating you for your 3 hours of time. All who filled out the online assessment, we weren't able to compensate every single survey respondent or incentivize them. But the larger incentive that we did say is that, 5 individuals will be entered into a raffle for a $100 gift card. So, there's pros and cons to doing that, but I just wanted to lay out, given the budget that we had, given the resources that we had, that's how we incentivized and compensated people who were sharing their stories with us. And I'll turn it over to Margaret now. We can go to the next slide to talk about, okay, well, who responded, who participated in this work?
Thanks, Alyshia. So we asked a wide variety of demographic questions that align with state standards around race, ethnicity, language, and disability. But we're just going to go over a couple of key demographics here. So, of course, the HEAL assessment was intended for Pacific Islander community members. Therefore, all of our 136 respondents reported one or more Pacific Islander ethnicities. This chart shows that community members reported 16 different Pacific Islander ethnic identities representing Polynesia, Micronesia, and Melanesia. We also have a couple of examples of some of the write-in responses that we received, which is a great example of the amazing diversity among Pacific Islanders and how many identify with multiple race and ethnic groups. And just a quick note, the ability to identify one's ethnicity at this level of granularity and specificity is not possible on the BRFSS or frankly any public health survey in Oregon that I'm aware of. Can you go to the next slide? Like the race and ethnicity question, we also invited respondents to select as many options as they needed to identify their gender. We also invited folks to write in a response. And once again, the response options we offered and the write-in answers we received really demonstrate the diversity of our respondents. And it's a significant departure, again, from what's possible on the BRFSS. You can go to the next slide. And then in terms of age, we had a very wide variety of ages of folks who responded, but the majority did fall between ages of 26 and 45. We had folks as young as 18 and all the way up to some elders in their 70s. And then next slide, please. And then in terms of geographic location in Oregon and Southwest Washington, this graphic shows where our respondents lived in those areas. And the majority said that they lived in the counties that were in and around the Portland and the Salem metro areas. A handful of folks were from more rural counties on the coast and in Eastern Oregon. And we know that there are large, thriving Pacific Islander communities in these more rural areas, among others in the state. So we hope that future iterations of this work can reach them. You can go to the next slide and I'll pass it back to Alyshia.
Awesome, thank you. And I think, what I want to emphasize here is what are the data points that we didn't necessarily put on the slide, but, with the racial and ethnic oversample that the state leads, I believe it took, Margaret, what was it? Maybe like, was it 3 years for about
Yes.
109 Pacific Islanders to respond?
3
And
years, yep.
okay. And we got about 150 engagements in 6 weeks, amidst a global pandemic. And I think that just speaks to the power of like what it means to have trusted community leaders be involved in the research process to organize and rally their people to say, hey, this is important and this will actually be beneficial to us. And so, let's take this platform and opportunity to share our experiences and our stories. And so speaking of that, we want to go over some of the results. So again, there's a ton in here. We're not going to go over all of the results in detail, but I did want to turn it over to Bella to just talk about, to just highlight some of the results that really struck us, that, the stories that we learned from our folks when they shared. And so let's go to the next slide. And Bella, I'll hand it over to you.
Awesome. Thank you, Alyshia. So the first category that I wanted to talk about was the place category. And so the first important finding was that 56% of community members reported that there was a low abundance of cultural centers that were accessible for themselves or their families or other community members. And really the dream for many community members and leaders who attended the workshop is to have a Pacific Islander specific cultural center to share ideas, to build connections, and to host community gatherings in Oregon and Southwest Washington. The community wanted a space to hold, wanted a space where all Pacific Islanders know they can go there to access resources, receive support, or to just connect with community members in general. And community members suggested that the center could be a hub for programs related to cultural education or youth mentorship, culturally specific health services or job readiness training, community gardens, and so much more. And it was also important to community members to recognize that this potential culture center will be built on Native American land. And so community members felt that the proper recognition was required to build stronger relationships between Native Americans and Pacific Islanders. Another important finding was the access to cultural foods. And cultural foods are hard to come by. Sorry, it's not on this slide, but cultural foods are hard to come by and typically available through social media, either for purchase or through community food drives. The cultural foods such as like koi, octopus, or even pandan are typically have to be shipped from the islands, having costs to the community members. And this is due to the cost of product, shipping costs, and minimum purchase requirements to ship overseas. And so availability, there was low availability for participants. And then if you want to go ahead and go to the next slide. So under the opportunity category, I wanted to highlight what community members said about local wealth. So 53% reported that local wealth was not something that their families or their communities had access to. Specifically looking at island groups in which people come from, we know that resources are distributed disproportionately to begin with, but even more so for smaller PI communities and specifically for Micronesia. We also know that wealth directly impacts access to safe housing, ability to purchase nourishing and nutritional cultural foods, and the ability to respond in emergency situations. And many Pacific Islander families are living paycheck to paycheck and finding livable wages or stabilizing career opportunities are really pervasive challenges. With the amount of barriers and challenges to stabilizing finances, community members noted that local wealth and future planning felt so out of reach that it was almost insulting to even have been asked that question in the HEAL assessment, or that it was included. And in addition to financial stressors, community members stressed how not being accustomed to the US or utilizing English as their primary language impacts access to study and employment. Also under the opportunity category, we found that institutions are deeply lacking in providing culturally relevant and accessible information to Pacific Islanders. And so information and resources are typically passed on for the community verbally or through existing community connections, and many community members need and want help, but they're not sure where to go or who to receive guidance from. And this includes medical translations or general contracting information, affordable housing access, support with taxes, etc. And community leaders express their own lack of understanding on what the government is actually able to provide, which emphasize that the community will not read information that is not in their own language. And if we could go to the next slide. So the last piece that I wanted to highlight was under the healing category. And so decolonization is rated at 58% of people stating they have no access personally for their family or for their community. And the level of decolonization is different for each group, specifically for those whose legal status depends on it. So what we found were that some were confused about the definition of experiences, whether that related to here in Oregon or back home. Community members gave important feedback on how confusing and loaded the definition was for the two terms that were on the PICO assessment. And so some community members also noted that while they understood what colonization is, that it was hard to imagine what decolonization could look like. That being said, community members still made the connection between how what happens back home impacts their experiences in Oregon, such as the desecration of Mauna Kea or the 70+ years of exile from Bikini Atoll. And community members also noted the importance of organizing for indigenous sovereignty, while recognizing that we must support leadership of those indigenous to Oregon's occupied lands, which is what I kind of mentioned earlier in the place category. And then another important finding was that healing in regards to healthcare. And so 50% of respondents felt that healthcare was not accessible to them or was minimally accessible to them. So access, comfort, and safety within the healthcare system remains a very large concern for Pacific Islanders. Community members want to be healthy, but they feel that preventative care opportunities and health insurance are severely lacking. These barriers have really transformed into fatalism, in which community members fear going to the doctors out of belief that it will be about outcome, and they're not able to financially or practically or even emotionally manage with their family responsibilities. There's also a need for medical interpreters who are subject matter experts and can speak the needed languages, will respect the privacy of community members, and are also of the same gender. And so community members fear that interpreters will spread the information. That's a huge concern, given that the tight-knit community relationships exist. And oftentimes children serve as medical interpreters, but they can be afraid to ask follow-up questions or may not be able to accurately interpret the information between the doctor and the adult. And so as we can see, healing has been difficult for the PN community who still experience the impact of colonization and access to health.
Thank you, Bella. And let's go to the next slide to close up our conversation on reports. So one of the visuals that's not on here is we asked the community members two different questions at the end of the assessment. One was to, prioritize, like, is this a low, medium, or high priority thing that we need to address to improve health. And what you'll see is across all 16 factors, right, there's an overwhelming response that all 16 of them are high priority for future efforts, right? Like we need to focus on these things. It's in critical condition right now, you know, and when we dove into deeper conversations with the community and we said, well, why is that? Why did folks respond the way they did? You know, the conversation that we had was this visual is really representative of the chronic disinvestment that Oregon or that Pacific Islanders have experienced in Oregon. Then the next layer of conversations we had, right, through the assessment was, okay, well, there's all these 16 factors. We're hearing that all of it is a high priority, but what are the top things that you believe we need to address? And so it's not on here, but what we heard from them was education, healthcare, and housing. Like those are really especially critical to move on, you know, out of these 16 high priority factors. And, you know, I'm not surprised by the education one, particularly because in every single conversation that we had with our community, they talked about youth development and they talked about education, not only in terms of, you know, success in early childhood or K through 12 Western systems, but education in terms of cultural preservation, you know, meaning preservation of both our language, our protocols, and our histories as Pacific Islanders. So there's a ton more that we could dive into, but I want to wrap up, you know, by going to, let's go to the next slide. So we told you all about, okay, this is the model we created. This is how we engaged our community in both being participants in this work and also being leaders in this work. Here's some of the data, the rich data and experiences that we got. So what's next? Let's go to the next slide again. So what's the path forward? So right now we've assembled a Pacific Islander Data Modernization Steering Committee, and it's made up of 3 organizations that participated in the project. Kalo HCC, which serves the Native Hawaiian community, Micronesian Islander community, which serves our Micronesian community, including our Kofa citizens, and then also Samoan Pacific Development Corporation. And so as a steering committee, they are really responsible for and have the power to oversee our entire dissemination process. We're in the dissemination phase of the work right now. We're also really working with them to operationalize the data sovereignty agreement. Now that we have all these, you know, exciting requests for data, for presentations, for future collaborations and partnership, right? Because, and we're doing that because we really want the steering committee to co-lead the strategic planning conversations on, now that we have this information, you know, what's next for the Pacific Islander community? There's also potential for us to design the next phase of research for this project. And so they'll be involved in that as well. And then they're also, you know, advising on the development of a youth data council for the student health survey. So reflecting on their experience of a community-led research model and trying to lend some of that expertise over, you know, to another body of the state's work. And some of the dissemination deliverables that we'll be creating with our steering committee is presentations to key strategic partners. We also hope to develop a policy brief. So what are some of the policy recommendations that come out from this body of work, given the stories that we heard? We also want a community brief, right? We want to write and, you know, potentially in different languages, but we want to be able to write out like, how do you use this as a tool? Because we don't just want it to be this report, right? That, you know, researchers get to claim as like, great, look at the work we're doing and we get to lead the conversation. We really want to be able to use this as a community organizing tool. And we want to be able to share it with the folks who, you know, were foundational to the work we did. So we're going to create a community brief as well. A lot of our folks were really excited about this work because this is the first time that they got to talk about health in this way. And so one of the deliverables that we agreed upon with our community was to actually create an implementation toolkit. So taking all of the materials that people like myself and Dr. Braun managed and, you know, making them templates, sharing with them the actual HEAL assessment, you know, links to the Survey Monkey, resources to learn about the social determinants of health, an example of the budget, an example of agendas, all those good things. We're putting that together to create an implementation toolkit so that they can utilize it. And then also, you know, we are hoping to, and this is more of what the state will be doing is, you know, reflecting on the report and on the work and creating a state report back document of like, how is this work and the experiences that Pacific Islanders shared shifting what the state is doing and how is the state going to respond to this, you know, as a partner. And let's see, let's go to the next slide. So I just want to end with some closing reflections before we go into Q&A and give my team some time here to just talk about, what you felt is powerful about this work, things that you think need to be strengthened, and Bella, I know you also wanted to talk a little bit about how you see this being impactful for MIC specifically. So I'll turn it over to you first, Bella, if you want to share some reflections with folks.
Yeah, thank you. So I think I'll start off with MIC and the impact to the work. So the way that I see this body of work being impactful is by utilizing the knowledge that was gained to help focus the efforts and target solutions by addressing the interconnectedness of issues. So specifically around the cultural place and cultural centers piece, MIC as an organization is in the process of purchasing a building in hopes of addressing some of those issues highlighted in the place category. And then also moving forward, one of the things that I hope to implement is utilizing the discussion and conversation time to elicit responses. So implementing that in a more formal way within workshops that are designed for the community with considerations such as availability to self, family, and community will hopefully be a strategy that I will continue to use. And so something powerful about the work was really being able to give voice back to the community from trusted leaders within the community. And especially in the middle of COVID, we really had an opportunity to validate responses and to really acknowledge how complex the needs were within systems. And so the fact that we were able to get more information about community made the work more meaningful and satisfying personally, and really, again, validates what the community is saying, even if statistics may not show that. And then something that I think would really strengthen the work is to hopefully in future iterations is to see included considerations for exploring and examining violence prevention and access to systems. Also, I just really appreciate that there's a comprehensive plan for dissemination, and that's really important because many times Pacific Islanders will engage in this kind of work and then they never know what happens to the information that they provide. So yeah, I think that in itself is strengthening the work.
Yeah, mahalo, Bella. I'll turn it over to you, Margaret, if you want to share some reflections.
Thanks, Alyshia. Thanks, Bella. I just want to share something that's powerful about the work for me, and also something that to sustain, I guess, keeping your foot on the pedal. So I have worked for state and local government in Oregon for over 12 years. And this is the first time in my 12 plus years of experience that government leadership has done something like this. Before this project, my experience with government had been the usual, my experience with community engagement with the government had been, something like, invite community, check the box, make a show that we've engaged them, and then just go ahead and do what we want to do anyway. And this has been very, very different and very, very welcome. And something that we need to sustain is really to continue to champion this work and be determined to not go backward. This project has drawn back the curtain on what true community-led research models can look like. And we can't go back to that typical token community input session approach. We need system level changes that incorporate community engagement as part of the structure of how we do public health surveys.
Awesome. Thank you, Margaret. And I couldn't have said it better myself. So I will +1 to both of your reflections. And with that, we can stop sharing the slides, but I just want to invite folks, whether it's in the chat or to unmute, if you please, certainly ask us questions or even just share like your thoughts on how this work is landing with you. We'd love to hear with you and be in dialogue for the next few minutes, for the next 15 minutes.
This is Rebecca. I work in Colorado, and this is just a small comment, but I was so struck by your fish Likert scale, if you will. It's not even a Likert scale, but and it was such a subtle way to involve communities and think about what actually the response metrics you use. And I was really just struck by that and the abundance language. And so I've heard talks around this survey before, and I always really appreciate it. But just the intentionality that went into every piece is something that I continue to try to take with me into my work. And so I just really appreciate all that you are doing.
Yeah, thanks, Rebecca. Yeah, the fish scale, she's become pretty popular. She's become a pretty popular research tool, and we're pretty proud of the fish scale, and the abundance model too. I think it's really different. And I think, like Bella, you were sharing, right? Like it's also with the local wealth example, it's really hard to talk about the abundance model because, it's hard for folks to think about what their visions are for the future when they're just trying to survive right now, right? So we had to be really thoughtful about disseminate or about how to facilitate those conversations. But yeah, I appreciate that. And I'm glad it landed with you in that way. Any other thoughts or questions, folks? We got a kudos in the chat from Roderick. Thank you.
Hey, Alyshia, this is Lynn. While we have folks in the audience, maybe thinking up some questions or anything, reacting to the content, I just have a curiosity for you all. So I know that this is a modification of the BRFSS or maybe an improvement, a massive improvement over what the BRFSS was doing. Do you have hopes for amending any other surveys in Oregon, or like what's next?
Ooh, good question. Margaret, I'll throw that to you if you want to share a little bit about how this is impacting the state's work.
Sure. So this is having huge effects on how Oregon is envisioning a path forward for data collection and community engagement as a division. In the immediate future, the next sort of survey or data collection method that we'll be tackling is the Oregon Student Health Survey, which, as I mentioned, is Oregon's version of the Youth Behavioral Risk Factor Surveillance System. It is a survey that goes out to 6th, 8th, and 11th grade students in Oregon, and has also not ever had community engagement as part of informing the content or analyzing the data or anything like that, and also hasn't even had youth engagement to inform the content. So Alyshia and our PIDM steering committee are going to be collaborating with some of my colleagues within my unit to stand up that youth council by nominating Pacific Islander youth to potentially serve on those committees, and then that they will work to not only represent Pacific Islander community priorities, but also Pacific Islander youth community priorities, which was actually one of the recommendations that came out of our Pacific Islander data modernization work and the HEAL assessment, was that there needs to be this increased focus on the needs of the young people within Pacific Islander communities.
Thanks, Margaret. And it looks like we've got another question in the chat, which I might also throw to you, Margaret, though we can tag team on it. It says, Julia asked, how would you go about disaggregating race/ethnicity, specifically with NHPI, so Native Hawaiian Pacific Islanders, in big data sets like UDS. A lot of people use UDS for grants or to serve as a needs assessment, but may not have any disaggregated data.
Unfortunately, Julia, you'll first have to tell me what UDS is.
And Julia, if you'd like, you
I can
yourself
speak
off.
Yes, sorry, my mic wasn't working. So UDS is Uniform Data System. So it's primarily used with like health centers. So all health centers are required to put in certain data requirements, but they may not capture everything. I'm currently working on a project and they're asking us to use UDS data, but this within like Native Hawaiian and Pacific Islander populations, but they don't essentially disaggregate. And this is really common with like CDC data and just really any national data overall. So like, how would you go about, getting the data if they're not even collecting it? How would you fight for it? What are some recommendations that you would do essentially to get that data to actually get accurate numbers?
Got it.
So the issue is that they aggregate right now Native Hawaiian and Pacific Islander, or is the issue that they aggregate Native Hawaiian Pacific Islander with other race and ethnic groups? Like oftentimes what we see is what they're aggregated with Asian.
So it's actually both.
Oh, okay.
Or it's default, like if they can't even, they don't know, they just default to white.
Gosh, that's a big question. I mean, in Oregon, we're lucky to have a policy that we refer to as Real D, which is race, ethnicity, language, and disability. So it's actually a policy. I think across all state agencies. It recently became a policy where for every data collection that any of these agencies do, mostly I think it's the State Health Authority and the Department of Human Services, they have to ask this series of questions that gets at every level of what I just said, those real D levels. And within those levels are, in my opinion, pretty great granularity. They do ask questions. Certainly they're all optional for people to respond to them, but from what they do ask questions about kind of the major, or in Oregon anyway, the larger Pacific Islander ethnic groups. So for example, there's obviously Native Hawaiian, and then there's also Marshallese, I believe, or maybe it's just kind of Micronesian or something like that. Alyshia might know, might remember at least what the different groups are. But gosh, if they're not even collecting it first, and it's a federal data set, I'm not sure how one would advocate for them to change their data collection methods.
What's interesting, I mean, and thank you for the question, Julia. Yeah, I think, having the Real D standards has been a huge leverage point for our community, right? And also community leaders were also involved in creating the Real D standards and what those granular categories were, right? So we have Native Hawaiian Pacific Islander disaggregated, and then like Margaret was sharing, all of the different categories that fall under that umbrella. But what was interesting, so before this state-led project or this state-sponsored project, we had done a similar project with Multnomah County, but we didn't collect any new data. We analyzed existing data and went through a community validation process. And Dr. Eileen Duldalau was the lead researcher on that project who supported us. And it was interesting because what she found was, she manually went through administrative data sets, both at the county, state, and national levels, and did some manual data disaggregation. right? To find, because what she was finding was that Pacific Islanders will identify themselves. We're a proud people, right? And so we want folks to know what clan we come from, what village we come from, if there's a specific island, if, you know, or if there's a specific nation that we're coming from that we identify with. And what she was finding that, you know, I don't think this response answers your question around accurate numbers, but we do know that folks are trying to make themselves visible. So if there is an other or right, like a small writing category, people will say, you know, I'm from the Mokuji clan, or, you know, I'm Chuukese, or, I identify as Native Hawaiian, Kanaka Maoli. And what Dr. Doldalau always tells us is, epidemiologists will not find what they're not looking for, right? So if it's not on their radar to even pull out data on Native Hawaiian and Pacific Islanders, that's not going to happen, even if our people are trying to advocate for themselves and make themselves visible in these small ways, like writing in their, race or ethnicity in the other category. So I don't think that answers your question, but those are some of the ways in which we've navigated things, right?
Thank you so much. Actually been following all your work for quite some time. I'm from Oregon, but I just moved to the Midwest for a PhD program. So
congratulations.
Yeah.
Good luck.
Thank you.
And I'll say really quickly too, I just typed into the chat that our unit is currently advocating to the CDC to adapt our Oregon BRFSS to incorporate this RealD policy so that our demographic questions will look different than what the BRFSS stipulates. But that has been a challenge.
Yeah. It's the other thing that I'll name too, just Julia, because you specifically asked about grants too, and I'm not sure of the specifics of the ecosystem that you're working within, but that's one of the significance of this report is much of the time, like our CBOs who are also chronically disinvested in and under-resourced, like they will have all these requests, but no relevant or meaningful data to share what's in their grant proposals, right? And that's one of the powers of this report is, when we as leaders sat down and read it, we're like, yeah, well, we've heard all of these things before, but now what does it mean to have, a state-sponsored research project really highlight and tell the stories of that data, right? So now we have this tool to kind of back up what we're sharing in our grants. The other thing I'll name is that, we as Oregon Pacific Islander Coalition are part of a, broader network of BIPOC decolonizing data researchers. And so we're just starting conversations now with foundations about what standards and data and information are they using to create, their metrics and guide the way they do investments and funding. But yeah, we're in the thick of it all. So we'll be sure to continue to share out lessons learned. But yeah, that's what we're navigating right now, the same waters, I think. Any other questions or even thoughts, folks? Don't be afraid to unmute or just throw it in the chat. Got about 3 minutes here, so maybe one more question before we close.
I bet folks are digesting and processing everything that you've shared, just because it's been, I'm sure, a massive undertaking for you all to make this change for the Pacific Islander community. And just as an aside, we still talk about your session from last year, Alyshia, and then we still have folks commenting on how much they're learning from the work that's happening in Oregon. And so I would assume that everyone's just trying to take it all in. And I know that I'll have to rewatch your presentation just to really, really learn more about what you all are doing and following your work. So it's so important.
Yeah. Yeah, thanks, Lynn. I mean, it's a huge transformation, right? It takes a ton of resources, and there's a lot of unlearning that goes into doing data and research in this way. And like Bella was saying, it requires a ton of humility, right? We have to come humbly to our community, even though we're the folks doing the data and research, right? Always seeing ourselves as, technical assistance providers, but at the end of the day, the community is the expert on what their experience is as Pacific Islanders. So it's really different. And I'm sure you're all feeling that if, you're wherever you are along this journey or process. But yeah, I mean, in this last minute, Bella, I just wanted to make space, and Margaret, if you folks have, any other last thoughts to close out, no worries if not.
I do, unless Bella does.
Go ahead. Go ahead.
So I just wanted to say a couple really quick things that because I know that there are some folks in the here today who are from the government, and they're probably wondering how in the world the government was able to do this. I just want to just touch on just a couple of things. You need a champion, and I feel like because my unit was we were well positioned to see all the flaws with the BRFSS because that's what we oversee. But you also need leadership support, and not only leadership support to say, yeah, you can do that, but also leadership support to try things and then also be okay if you're not successful. We tried a couple of different things. We had support from many different health officer directors in our time over the last couple of years, and they were all okay with us failing. But we just wanted to try these new things, and also, jump at opportunities for funding to see if ideas get funded, even if those ideas aren't fully thought out yet. I think, for one of these iterations of getting general fund, I think to get the general fund dollars actually for this work, my director was contacted, and she was like, she had like 30 minutes to throw together a paragraph to submit to the legislature to get funding. And she was like, okay. And so she just kind of typed it out and it was funded. So yeah, search for those opportunities to get funding, even if your ideas aren't there yet.
Thanks, Margaret. Bella, anything before we close?
Yeah, so one of the things I think that is super important to highlight from this is utilizing community leaders who have established trust with the community to be able to do this work. Because no matter, the credentials that you may have, the experience that you may have, people are not going to share personal information about themselves without that trust. And so really taking the opportunity to invest in the community itself and, hiring on community leaders to do the work, even if they don't have the same credentials as you or, the same formal education that you may have or are used to from people who typically do this work.
Yeah, thank you. Thank you both. Well, we'll close here because I know we're a few minutes over, but thank you to the City Match team for having me year after year and for giving our team the space to talk about this body of work. And thank you all for, sitting in to listen, to be curious about our work. And yeah, we hope to hear from you and hear about the work you're doing to decolonize data and research. But yeah, thank you, everyone. And I hope you all have a good rest of your conference.
Thank you so much, Alyshia. Thank you, Bella. Thank you, Margaret. It's been such an honor to have you be a part of our conference and share your expertise and your work with our audience. Thank you again for your time. I hope that you all have a wonderful afternoon. And for those still in the audience, please join me in giving kudos to our presenters today.